radiation safety, one of the most important things you need to consider is your radiation monitoring device. So what it is called a dosimetry badge, and it measures the amount of, it's sensitive to X-rays, beta rays, and gamma rays, and it measures the amount that you're exposed to throughout the day, and most importantly when using equipment that emits radiation, most specifically and most commonly through taking radiographs. So basically, like I said, how it works is it's sensitive to those X-rays, the beta rays and gamma rays, so it kind of gets all those different ones that you may be exposed throughout the day through different types of equipment. So then as we're wearing it, it's going to be measuring those, and then in order to obtain those readings, you will send your badge either quarterly, monthly, biannually, depending on how much your clinic actually uses the equipment and how much you're exposed to the radiation. You know, smaller clinics may do send it less often, but a really busy clinic may send it, you know, as often as every month. So how it works is you'll send your badge back to the manufacturer. They'll send you one at the same time, so you're not getting any lapse in monitoring, and you'll send it back to the manufacturer. They'll read it, and then they'll send you a dosimetry report back to your clinic, and it'll kind of give you an idea of how much radiation you've been exposed to. As far as the badge goes, you do need to wear it throughout the day. While you're at the clinic, you don't want to take it outside the clinic, you know, because it could be exposed to any other excess radiation, such as even sunlight, heat, things like that. But you do want to wear it every time you're using any radiology equipment. You have to, when you're wearing it, you're going to put it outside of your gown and around the area of the thyroid glands. And as far as dosing goes, your maximum permissible dose is the maximum amount a veterinary staff member can get annually, and for staff members that is 0.05 SV per year. And so then you're going to get a dosimetry report back from your manufacturer, and you know, you're going to have one designated person that monitors and keeps track of everybody's dosimetry reading. Here I do have an example for our clinic. I am going to go over one of our staff members. So for this staff member, so your dosimetry report will have all of your clinic's information, your account number, things like that, and we'll go through each participant and their report. They'll have their ID number, their birthday, their name, how long, you know, it'll say what date they started, you know, monitoring, and it'll go through each period dates and what period you're looking at for the time. It'll have quarter to date, year to date, and lifetime to date. So for the period shown, it'll go over the deep dose equivalent, it'll go through the lens dose equivalent, and it'll go through the shallow dose equivalent. And for this person, it looks like for this period they did have a DDE, LDE, and SDE of 10. So basically that is in your normal range, and you want to just make sure that you are staying under that range. So the next important thing that is, as far as radiation safety, is going to be your personal protective equipment. So this is what's going to be able to protect you. These are your lead equipment that is going to be able to protect you best as possible from the scatter radiation that you're going to get while taking your images. So the different personal protective equipment is going to be your lead aprons, including a thyroid shield. Sometimes those can be attached or they can be separate. And then gloves that don't have any holes or anything like that and completely protect your entire hand. And eye protection. So we don't have eye protection in our clinic, but that does protect your lenses against the scatter radiation. So before you put on your PPE, you do want to make sure that there is no cracks or anything like that that may need further inspection. You know, maybe take some x-rays of it to see if there's any radiation that is getting through the lead. The good way to keep your protective equipment stored is either hanging it, like just on a hanger, or over round bars like we have here. That way that there is no crack, you know, just decrease the risk of cracking and things like that. do notice any cracks, like I said, you do want to check them. You do want to check your equipment every time you're taking x-rays for any sort of cracks. So other than that, you do want to make sure you're as covered as best as possible. So as far as the lead apron, you do want to make sure it is covering your entire body and does totally fit and is completely secured in. So putting that on, and then you do want to get your thyroid shield on, not too loose to where there are any parts of your neck showing. And like I mentioned earlier, you do want your dosimetry badge out up in front of your gown as close to your thyroid area as possible. And then as far as gloves concerned, like I said, there are some that have fingers attached, and you do want to have those on, covering your arm and your hand. And then if you have any eye protection, you will wear that as well. So in addition to the two things I've previously mentioned, your dosimetry badge and your personal protective equipment, there's many other things you need to consider that are super important when taking your radiographs. The first thing is how you're going to be restraining your patient. So there are 3 different kinds of restraint. There is mechanical restraint. So that will be things such as like gauze, tape, sandbags, troughs, wedges, different things like that that will physically do the holding of the patient for you. Sandbag, such as example for sandbags, they'll be able to hold down the head or legs and things like that, so you don't have to while taking the radiograph. The other thing is going to be chemical restraint. That is always like the best thing to use as far as restraining goes. But you do always want to consider, is this patient able to go under chemical restraint, because you do, if you're taking radiographs of an ill patient or, an unstable patient, you don't want to be using that chemical restraint. And you do want to take the best, be aware of any risks to the patient and, decrease those risks as much as possible. Is the chemical restraint, medically necessary? So as far as the chemical restraint goes, that's sedation, anesthesia, analgesic, things like that, just so that your patient is going to be as immobile and still and quiet as possible. So by doing that, that does decrease the amount of x-rays you're probably going to take, so decreasing the amount of exposure as much as possible. The third one is the manual restraint, and this is the least ideal form of restraint, but sometimes you do have to use it in certain cases. So that, going back to those mechanical restraints, 3 positioning aids that we have for that in our clinic. The first one is going to be a V-trough, and this is great for, holding them in like the ventral dorsal position, having them on their back, so you're not having to, they're going to stay still in that upward position and keep them as centered in that beam as possible, so you're not having to kind of finagle them around as much and kind of hold them up, be an extra hand for you. So another one of the things that you can use is a wooden spoon. These are great for things such as limbs, holding out, you can hold, even maybe like hold down a leg, hold down a head, just because of kind of an extension as your arm, getting you just that much farther away from the direct beam. A third one is going to be things such as like gauze. You can use that to hold out legs, extending them, keep things elevated or in the correct angle. Like I said, just another thing that's an extension of your arm that keeps you out of the direct beam as much, or, as close to that direct beam as possible. So those are 3 different positioning aids that we have in our clinic, and I will be demonstrating how to do those later in this video. Another great way to decrease the amount of scatter radiation that you're getting is just to use physical barriers. So a lot of radiology suites will have their buttons on like the other side of a wall, or so using any other side of a wall or behind anything that is another barrier between you and the machine and the direct beam, just decreasing that amount of scatter radiation. So 2 big things that you do need to consider as far as taking your images, that kind of goes back to everything I mentioned, is distance and exposure time. So I've mentioned before, getting yourself out of the way of the direct beam and decreasing the amount of scatter radiation. So the closer that you are to the direct beam, the more scatter radiation you're going to get. So the best, everyone kind of says 6 feet is a good judge point. So certain machines like ours will have, buttons that are attached to wires that are, this one's pretty long, you can get yourself out the door, anything like that. There are, like I said, there are some radiology suites that have your buttons on the other side of the wall, just kind of out of the room to, as far as distance as well as time. So you want to, when you're setting up your measurements and everything, you want to do the least amount of exposure as possible to get the best diagnostic image you can. So, having least amount of radiation going at once, and then, with making sure you get the best diagnostic images at the first time. So with that decreases the amount of images you do have to take, and decreases the amount of radiation that you're getting. That goes back to like what I said with the restraining, going back to the chemical restraints. Like I said, it keeps them in the, you can better position them to get the most diagnostic image possible. So really what you're doing when taking your images is, how can I do this the most efficient in the least amount of time, just so that you're not spending as much time exposed to the radiation as possible. I talk about the primary beam a lot. So the primary beam is what is, in this light in your collimation that is getting the direct source of the radiation. This is great for taking the images because it's getting the radiation to the patient, but it's not great for us because that's exposing us to the direct radiation, which we do not want to do. The problem with that, whether or not, it doesn't matter if you're shielded or unshielded, you're still going to be exposed to it because the lead in your protective equipment is not thick enough to protect you from the direct beam. It's only thick enough to protect you from the most scatter radiation as possible. Decreasing the amount of exposure, you want to have the least amount of people in here as possible. So if there's an extra person that doesn't need to be there, they're getting exposed to the radiation when they don't need to. In addition to that is making sure that your clinic is rotating people so that the same people are not taking the image every single time and just adding up to their dosimetry readings. Like I mentioned before, I'll just mention this again, try and get those diagnostic images the first time. This just goes back to decreasing your exposure time and really just getting you through those x-rays as fast as possible, but the most efficient. If you can get that great that great image of your radius ulna the first time, then that's less that you have to take, you don't have to take any more after that, further increasing your exposure time. The last thing you need to consider as far as radiation and taking x-rays go is anyone that is under 18 or is pregnant does not need to be taking x-rays. They both have cells that are undergoing mitosis, that are growing. 18-year-olds as they're still growing, or pregnant women have, their babies that are definitely growing a lot. And that ionic radiation is those cells undergoing mitosis are super sensitive to that ionic radiation and could end up damaging those growing cells, and that could, be potentially super harmful for anyone who's growing or any growing fetuses. Okay, so the first study we're going to be doing is going to be the craniocaudal radius ulna. So the first thing I'm going to do is to just set up my study. So you're going to go ahead and register the patient. Okay, and then you have the patient's name, the last name, their birthday, the age, sex, whether they're neutered or not, the doctor's name, and this is all going to be part of our permanent label. So I'm going to go ahead and start the study, and then since we're doing the radius ulna, we're going to go ahead and say whether or not it's the left or the right leg. So we're going to go ahead and do Rudy's right leg. So we'll do the right front extremity, and we'll make sure to do, with this one, they only have VD or DV, but since we're doing the craniocaudal, we'll go ahead and use DV. And then I already have my study ready to go, and this little green mark says that is ready. And then next I'm going to go ahead and measure him. All right. So like I said, we're doing the radius ulna. So we're going to go ahead and measure at the thickest part. So for him, it's going to be at, make sure that this does stay straight and you're not diagonal in any way, messing up the accuracy of your numbers. So for him, it's going to be at 5 centimeters. And I already have our technique chart ready to go. And for extremities for 5 centimeters, ours is listed for 70, 25, and 0.04 seconds. All right, so now that I know that, I'm going to go to my machine, and I'll do 70 kV to 25 MA and 0.04 seconds. I'm going to start. Okay, so now that we've got our machine set up and our measurements made and our study set up on the computer, we're going to go ahead and take our images. So for the radius ulna, we're going to want him on sternal recumbency. You lay down, bud. It's okay, bud. You can lay down. Good boy. Okay, so now that we've got him in sternal recumbency, we're going to go ahead and fix the collimation. Also, I want to note that while we're taking this image, we're going to be using some positioning aids. So I do have a rope that we're going to be using to make sure that his leg stays extended. And we're also going to be using just a wooden spoon that we can just use to hold his elbow as well. So for this one, we're going to have the collimation in the midline, the medial part of the radius ulna, which we have already done. And then we're just going to adjust the sides, so that the side of the elbow and the distal of the carpus. So I have his other leg out of the image, and I have the X of the light right in the center. And all right. Okay, so the next study that we're going to be doing is going to be the VD thorax. So I'm going to go back to our computer and set up another study. So set up with all the patient information, patient name, last name, client name as well, and then birthday, he's going to be a male, neutered, got the doctor's name, and I'm going to go ahead and start the study. And so, like I said, we're going to be doing the VD thorax. So I'm going to go ahead and put a left marker so that when we do it, you're going to find, that way we'll know where the left side of his body is. And and then our study is set up and ready to take the image. So the next part is going to be to go ahead and measure the site that we're taking. So for the thorax, we're going to be taking the measurement at the deepest part of his chest. And make sure that this part is level. And so for Rudy, it is going to be 22 centimeters. Alright, and so looking at our technique chart, for the thorax, 22 centimeters, it'll have 90 kVp, 15 MA, and 0.12 seconds. So 90, 15, 0.12. All right, and we're ready to take our image. Okay, now that we've got our measurements and we've got our machine all ready to go, we can go ahead and get Rudy positioned for the VD thorax. So I already have our V trough set up in the light beam. So we're going to go ahead and land him on his back. I'm going to go ahead and get my gloves on. If you want to pull it, you need a couple more. All right, so as far as collimation, we're going to have the middle of the X and the midline right behind the shoulders. So you can actually scoot a little bit farther that way. And then our light is going to be at the lateral borders are going to be at the edges of the body wall. And then we're going to make sure to have the line directly down this midline of his body. And the top image is going to be and then, so the bottom is going to be at the first vertebrae, and then we're going to have the top right at the start of those ribs. You do want to make sure he is as centered as possible. So when it shows up on the image, everything is nice and symmetrical and centered. All right. So for the OFA quality of the pelvis, the first thing that you're going to want to note for this view is it's best to have your patient under chemical restraint, which we already have Rudy under now. That way they're more relaxed, and that way they can, we can get their position right and really make sure that their hips are in the correct position for the OFA quality view for their hip dysplasia. So we do already have Rudy in dorsal recumbency, but I am going to go ahead and measure his hips, and you're going to go ahead and measure at the thickest part. And for him, it looks like he is going to be at 11 centimeters. So I'm going to take that and look at our technique chart, and with this machine, 80-20 for 6 seconds. Alright, and so we've both got our PPE on, got our gloves and our gowns, and so when you're doing, it's okay, but hey, shh. Alright, so when you're doing this, you're going to position his, when you're positioning your legs, your pelvis for the OFA quality, you're going to make sure that his legs and hips are complete as parallel as possible. And then you're going to rotate his legs inward, and so that they are going to show up parallel on the image. Alright, now that we've got them in position, and I'm out of the beam, so more times than not in your clinic, you're going to want to have to go back to previous x-rays you've taken and, relook at, pull them up for the doctor to look at them again, or just anything else that you're going to be needing to, and just anything else you may need to look at them again for. So I'm going to show you how, we have a digital system here in our clinic, and I'm going to show you how to pull up a previously taken x-ray with our system. So the first thing you're going to be doing is going to your database. So there's different ways that you can search for a patient. You can go by patient name, condition, the ID, the account number, things like that. You can look at any particular dates and say, I need to look at the x-rays between, the 10th and the 14th. You can look at all the different thorax, all your thorax, all your abdomen, things like that, all the females, males. You can search with the x-rays taken within today, within the week, or within the month if you know exactly kind of when your x-rays were taken. Okay, so when you're searching, you can search by, one example can be through searching the patient's name. So you'll type in the name that you're looking for. And then you can set some date parameters. We'll go January of this year through, this month, today. Just to kind of get a broad search, and then you can hit search and it will pull up that specific one you're looking for. It'll pull up your images and then you can open it, edit it, insert images, things like that. It's okay. Alright, so we're going to be performing a contrast study with Miss Gypsy today. So we're going to be looking at her upper GI tract, and today we're going to be using barium as our contrast. I already have it pulled up and ready to go. So like I said, we're going to be looking for the upper GI, and when we're doing contrast studies, we're looking for to see if there's any obstruction. Usually the patient comes in, with different symptoms that we are suspect of there being obstruction, if they ate something, anything like that. So this is just and we're going to administer the contrast, and we're going to take an initial x-ray, and then every about 15 minutes or so, just to watch as the progression of the barium through the GI tract. And if it ends up stopping, then we know that there is something that's blocking that from going through. So I'm going to go ahead and administer the barium first. What we're going to do today is just to administer it through the buccal pouch, just orally. So, all right, Miss Gypsy, so we're just going to use some of this thing. All right, sweetheart, it's not going to taste too good, huh? You do want to make sure. I know, honey. You want to make sure it's not getting on them as much as possible, on their fur, anything like that. Now that we've administered the barium, the first image we're going to take is immediately after the administration, just so that we have a baseline of, the beginning and everything like that. So we have a baseline. So we're going to go ahead and do a left lateral of the abdomen. I've already got her measured and set up with our technique chart, and I have our study ready to go on our computer. All right, let's see. All right. We're just going to make sure that we've got her whole upper GI tract in the image. Alright, and as you can see, we have got our first initial image labeled with our permanent labeling and everything like that. And now that we've got our first initial image, we're going to go ahead and wait 15 minutes until our next image is taken. Okay, so it has been 15 minutes since we took the first initial x-ray as a baseline. Alright, so I have everything measured and ready to go. Everything is set up with my machine. So we're going to go ahead and get Gypsy in lateral competency. Good girl. Alright. And like I said, we're doing the upper GI tract, so we want to make sure we've got everything, her entire abdomen in the frame. And as you can see, we've gotten our second image, and you can see that the barium has already moved down her GI tract.
Marty Turner, DVM, Brooks' employer. I think that as far as radiology skills, Brooks' strengths are mainly that she knows what she's looking for in an ideal x-ray, both in positioning and technique, that she keeps trying until she gets what she knows to be right. If she had weakness, I would say, is there's still those x-rays occasionally that don't fit that ideal, just like anybody has that. So I think I've seen Brooks' improvement be continuous from the time that she's kind of started these classes and then working here longer. Just every time she takes an x-ray, there are fewer and fewer exposures, which is good for the animal and it's good for the personnel. So she's just streamlining her skills, and I think she's doing a great job, and she's progressing the way I think that she should.